speak today because Dr. Matsumoto came over from the VA to give our mini didactic today. Dr. Matsumoto is a geriatrician and an endocrinologist. He is the director of clinical research over at the VA GREC, and also the associate director of the clinical services over there, and has been a practicing geriatrician for a while. He runs the osteoporosis clinic at the VA, and is an expert. You know, he's a world-renowned researcher for his work in testosterone, and he's going to talk to us about this today. We don't usually get a world-renowned expert to come talk to us about a topic, so thank you so much for coming.
Thanks, Kate. Appreciate the opportunity to speak about this. It's not your typical geriatric topic, but I think I'll convince you that it's important to recognize what to do in the situation when you're dealing with geriatric age populations. My disclosures, I think, relevant to this presentation. I have research support and consultation with AbbVie, who makes the testosterone formulation, and I was a member of the task force that developed and published the testosterone clinical practice guideline for the Endocrine Society. Game plan today, a game plan, and the goal is to try to convince you of how to appropriately treat individuals with testosterone. And the outline will be to talk a little bit about what the challenges are in older men when it comes to this topic, who to treat, what to treat, how to treat, and how do you monitor testosterone therapy. So geriatric challenges, and this should not be new for anybody that takes care of old folks. The key variable, or the key word here for geriatrics is multifactorial, okay? So aging is associated with a decrease in testosterone, such that, in fact, an increasing proportion of older individuals, older men, develop low testosterone levels. And associated with that is an increased prevalence of age-related conditions like decreased sexual function, decreased mobility, bone mineral density, that could actually be caused by low testosterone levels. However, for both low testosterone and for these non-specific symptoms and signs that could be related to low testosterone, there are multiple causes, mostly related to age-associated comorbidities and medications that become increasingly used as men get older. I think it's also worthwhile, once somebody started on testosterone, to keep in mind what differences there are maybe in pharmacology of testosterone. And the clearance of testosterone via the liver is reduced as a function of age. And as a result, you know, individuals that are older may not need quite as much testosterone as maybe your younger individuals. And then finally, I think an important point is that you are all familiar with the fact that with increasing age, there's an increasing prevalence and incidence of cardiovascular disease and prostate cancer. So if an individual is treated with testosterone and happens to develop an MI or prostate cancer, it's going to be very difficult to really know whether or not testosterone treatment was a contributor or not. So that's a challenge, particularly when there's a lot of press about cardiovascular events related to testosterone treatment or prostate cancer related to testosterone treatment. So who do you treat? Well, keep in mind that the only indication for testosterone treatment is hypogonadism. And what is hypogonadism? It basically requires two major things. It requires some clinical manifestation associated or caused by low testosterone levels, that is, symptoms and signs, as well as a consistently low, repeatedly low testosterone level, at least on two occasions. At least on two occasions, because there's quite a lot of variability day to day in testosterone levels, such that 30% differences can occur day to day. In the AM, preferably, because there's this diurnal variation in testosterone levels, such that testosterone levels drawn in the afternoon or the evening are lower than those in the morning. And also fasting more recently discovered that glucose infusions or food intake can actually suppress testosterone levels. So to not overdiagnose individuals with low testosterone, you want to make sure that at least one of the values that you get is in the morning fasting. I think one thing I want to emphasize, and I could spend a whole hour talking about this, because I actually, it's one of my missions in life here, in academic life as well as clinical life, is to make sure that we have accurate measurements of testosterone. And what I'll tell you right now is that testosterone assays, measurement assays of testosterone vary considerably, and the vast majority of assays that are done in automated platforms in clinical labs are not very accurate, in fact, somewhat downright inaccurate, okay? So it's important to actually, when it comes down to making a clinical decision, to use an accurate and reliable testosterone assay. I've been involved a lot with the, setting up a program with the CDC, Centers for Disease Control, to actually certify assays, standardize assays for accuracy. So I think ideally what you would want is an assay that is CDC certified to be accurate. Suffice it to say, if you utilize symptoms alone or a low testosterone alone for defining hypogonadism, you'll overdiagnose individuals and overtreat individuals. And I think it is done quite frequently in practice from my experience and seeing what's happening, both in the community as well as in the VA where I practice. So here's a list of symptoms and signs of hypogonadism divided into sexual, psychological, and physical. I'm not going to go through each one of these because we don't have time to do that. But I want to make 2 points. Except for the poor sexual development as a result of inadequate testosterone production, which isn't really relevant, right, to the geriatric population, all the other manifestations of hypogonadism are nonspecific. And you can see, just run down the list and you'll see that there are lots of things that could be due to geriatric syndromes, that could be due to other comorbidities, could be due to medications. So it's important to consider 3 things before you consider testosterone treatment, okay? Number 1, because the symptoms and signs are nonspecific, they could be caused by other things, comorbid illness, depression, medications. And so I think as good physicians, not just good geriatricians, but as good physicians in general, you'll be considering, you know, the clinical presentation and actually treating that, maybe without testosterone initially, to see whether or not there's improvement before resorting to a testosterone prescription, okay? Secondly, and I think most people recognize the fact that testosterone can be suppressed acutely with illness or malnutrition or certain medications like opioids and glucocorticoids. So it's important if someone has a COPD exacerbation and has a pulse of prednisone or is on MS, sustained acting morphine sulfate for an acute pain problem, not to measure testosterone, you know, during that period of time or a certain length of time after that. And then finally, I think not recognized very often is the fact that there's a common hormonal pattern that occurs as individuals get older as well as they get obese particularly. And that is, someone could have a total testosterone level that is low, but when you measure a free testosterone, which is the 1 to 2% that actually is biologically available to tissues, to act at tissues, that free testosterone could actually be normal. So in my estimation, when you're dealing with older individuals and you're considering testosterone treatment, you ought to make sure that the free testosterone measured in an accurate method, dialysis or calculated, not by a direct immunoassay from most clinical labs, which is totally inaccurate. You ought to make sure that a free testosterone is measured and is low before you consider treatment. Also important is to ask, once the diagnosis of hypogonadism is established, symptoms and signs, consistently low testosterone levels, think about what might be causing that. And there's 2 categories that you need to think about. One, is the problem in the testis, or is the problem in the pituitary or hypothalamus? And primary hypogonadism, a testicular problem, will be associated with high LH and FSH levels, gonadotropin levels. very similar to a menopausal woman who has high LH and FSH levels because of ovarian failure, or is the problem in the pituitary or hypothalamus, where you'll have either low levels of gonadotropins or inappropriately normal levels. More important, I think you need to think of hypogonadism in two flavors or two categories. That is the hypogonadism organic or is it functional? And organic causes are either congenital or destructive, or there's some structural problem in the hypothalamic pituitary testicular axis. And they are mostly irreversible, and they're mostly very severe hypogonadism that occurs, severely low testosterone levels. On the other hand, functional causes are causes that in fact occur when the entire reproductive axis is really intact, but there's a reversible suppression of LH and FSH that occurs, maybe because of opioids or glucocorticoids or obesity. And the importance of this for practitioners is that these are more common than any of the organic causes. Okay, so these are the more common situations that you'll run into. And more importantly, related to testosterone therapy, is that testosterone therapy may not actually be needed in these conditions. You may in fact use it as a teachable moment for patient care, and saying that, you know, your low testosterone is due to your weight, and I think we should work on your weight before using testosterone replacement, and see if that actually motivates individuals to lose weight. So who do you treat? It's mainly unequivocal hypogonadism, individuals with severe symptomatic or functionally impaired that have consistently and severely low testosterone levels, have no other confounding causes of the symptoms or low testosterone levels that are organic or irreversible functional etiologies. Irreversible functional, for example, would be somebody that is on a methadone maintenance program, that's on high-dose methadone, that is not going to get off in the foreseeable future, that has symptoms and signs of severe hypogonadism, has a testosterone level in the castrate range. Okay, so that's pretty irreversible for at least for a pretty long time. Okay, what do you treat? Now, the meaning of this is, so of all the manifestations of testosterone deficiency, what do we have evidence for testosterone treatment making it better, okay, or improving? And the best trial for, and really the only and the largest trial of testosterone treatment in an older population is what's called the testosterone trials, or the T trials. A coordinated set of double-blind placebo-controlled trials of testosterone versus placebo for a year duration in nearly 700 or nearly 800 men over the age of 65 with both signs and symptoms of low testosterone and repeatedly low testosterone levels, looking at 7 different outcomes, and we'll talk about the results of those. And importantly to remember that that we also did adjustments for the actual level achieved by a standard dose, and the dosage was adjusted so that the levels of testosterone could be maintained well into the normal young range. So what did the testosterone trials tell us? They told us that in fact treatment of older men with hypogonadism resulted in a moderate improvement in sexual function, and a relatively small improvement in positive and negative moods, as well as depressed mood, and an increase in walking distance in all the men. No improvement in cognitive function, but a fairly dramatic increase in bone mineral density, estimated bone strength, hemoglobin in both anemic as well as non-anemic individuals. And also somewhat concerning, although the clinical significance is unclear, it increased non-calcified coronary plaque volume. It also increased the number of men who had high hematocrits or hemoglobins. And there was no increase in cardiovascular or prostate adverse events. But again, this is not powered to actually know whether or not that's a problem. It did not tell us, the testosterone trials did not tell us anything about long-term risks and benefits. So you have to keep in mind that we don't know what the effect of testosterone therapy is on any of these outcomes listed here. So what do you treat? Based on the testosterone trials in older men with hypogonadism, I think we have pretty good evidence that you might expect improvements in sexual dysfunction, bone mineral density, and anemia, and possibly with vitality, strength, and mobility. But I think key point is that for all of these manifestations, there are effective treatments that don't rely on testosterone therapy. For example, in sexual dysfunction, individual could in fact respond very nicely regardless of the testosterone level if you switch them off of an SSRI or use a PDE5 inhibitor. If they have low bone mineral density, calcium, vitamin D, bisphosphonates might be beneficial, independent, again, of the testosterone level or testosterone treatment. And for these individuals with decreased strength and mobility, maybe nutrition, exercise, and physical therapy might be helpful. So how do you treat? So part of the how is to make sure you consider what the contraindications for testosterone are and what the relative cautions are. Okay, and listed here are the absolute contraindications are active or untreated prostate cancer or breast cancer. And the cautions relate mostly to individuals that have unevaluated abnormalities on their digital rectal exam, a PSA that's elevated, severe lower urinary tract symptoms, hematocrit that's borderline high, untreated or uncontrolled obstructive sleep apnea, congestive heart failure, or have had a recent cardiovascular event or congenital thrombophilia. So I'm not going to go over the risks and benefits, but before you start testosterone treatment and the how to do this, you have a discussion with patients about what the benefits and risks are. And it's important to identify the patient-specific goals. For example, I always like to use the example of individuals, doctors that want to treat sexual function when the patients actually want to improve their energy and strength so that they can take care of their disabled spouse and are not interested at all in sexual function. Okay, so patient-specific goals are very important, and long-term cardiovascular risks as well as prostate cancer risks are unknown. A couple of points about testosterone formulations. The use of shorter-acting injectables or transdermals are probably the way to go for older individuals because, number one, they're pretty reliable, and they are relatively short-acting. If you use an implant or a long-acting injectable formulation, if somebody should develop an adverse event, it will stick around longer. So for an older individual, it's probably not so good. And these shorter-acting formulations that you have to give twice a day, I can't even take something twice a day, are really relatively impractical for older individuals that may have a lot of medications. So monitoring, it's important to monitor both efficacy as well as adverse events. And I think another key point here is that if you have no improvement in what you're treating, the testosterone levels have normalized, and the patient is adherent to the therapy, there's no reason it should continue and that you could stop treatment at that point. I think it's important to also recognize that in this day and age, prostate cancer monitoring should be a shared decision-making process. It's not something that you dictate because there's a lot of concern about actually over-monitoring individuals and actually going to and diagnosing prostate cancer that's not very aggressive, that has no effect on lifespan. And finally, there's no need to monitor lipids or LFTs. So the take-home points for this mini didactic, as it's called, is that we should be treating individuals with definite hypogonadism, signs and symptoms of low testosterone, as well as consistently low testosterone, at least on 2 occasions. That we should try to emphasize in older individuals AM fasting, at least in one of the testosterone measurements. An accurate assay is important, and free testosterone, particularly in older individuals, is very important. And that prior to treatment, you consider other causes of the symptoms that are present or the low testosterone levels, as well as functional or potentially reversible causes of secondary hypogonadism, and treat those before reaching for testosterone as the therapy. Discuss benefits and risks relative to patient-specific goals, and during therapy, monitor both efficacy and safety. And finally, again, I'll emphasize long-term cardiovascular prostate risks are unknown. So we can't really really advise anybody to take or not take testosterone based on the risk of cardiovascular events and prostate cancer. So thank you.
Thank you
And
very
questions? No questions.
Sometimes it takes a second. If you have a
Okay.
question for Dr. Matsumoto, you can just raise your hand